University, Kampala International University, UCU, IU, almost all the universities training medicine are in partnership with us. And yeah, in case you're not represented or you know a university that whose students are not benefiting from these sessions, kindly reach out. We do have a coordinator who we shall share at the end of the session as we're sharing our banner. So once again, you're welcome. In the next 2 minutes, kindly remind anyone else you think should benefit from this session to let them know they should log in. Thank you. Okay, it's 4 minutes past 7, and we'll open this up so that we can start. This session is strictly 1 hour, so we'll make use of our remaining minutes. Once again, you're welcome to our clinical pathological case series that do run once every month in partnership with Seed Global Health. And as a disclaimer, everything we teach here, yes, is educational, and it should never replace your clinical acumen in taking care of patient. Pick something from here and apply it to the patient that you see that is before you, and put everything into context. So you're welcome. And our presenters for this month's CPC session, we do have Jasper Obale from Gulu University, fifth year medical student. He will say hi in a minute. And then we have Ariatemba Duff, who is an EMT student. He will also say hi. And our expert for this session is Dr. Emeron Joseph, who is an emergency physician. He will also say hi. I think we'll use the 1 minute just to do a brief introduction. My name is Anna. I'm an emergency physician, and I'll be your moderator for this session. In case just a few housekeeping rules. If you do have a concern or a question, feel free to type in the chat. You will be responded to. And for the question that I aren't responded to in the chat, we shall give a minute or two for people to open up their mics and actually do ask and get a response. And then for anything that is not attempted or answered in this session, do not feel like you've been cheated. We do carry on podcasts where we get to go an in-depth discussion of some of these interesting cases. So we do share these podcasts later on, and we attempt the questions that appeared the most, and we didn't get time to actually do a direct answer to your question. So do not feel cheated. Please type your questions. Everything you want to ask, be sure we shall be able to attempt it at some point. And then please mute your mic, mute your videos so that we can have a good smooth running of this session today. Otherwise, once again, I want to welcome you all for this session. Hang in here for the 1 hour that we are here to learn. Thank you. Jasper, can you unmute and say hi to the team? Okay, Jasper is getting ready. Duff, do you mind introducing yourself briefly?
Thank you, Dr. Anna. Once again, my name is Ajati Ambadaf. I'm a student at Ruaga Hospital Training School, and I'll be the pre-hospital presenter of today. Thank you.
Well, you're welcome, Duff. Dr. Emeron, kindly unmute and just do a brief introduction.
Hello, everyone. Good evening. Thank you so much for joining. This is Dr. Emeron Joseph, an emergency physician at Katak Regional Hospital. I'm glad to be part of the conversation today, and I look forward to active participation. I encourage all of us to actively participate in the discussion.
Thank you, Dr. Joseph. So Jasper will introduce himself at once as he's coming in to present. So our theme for this month is he's vomiting. He was vomiting blood. So we shall get to see what this big theme is trying to showcase. So over to you, Duff, for the pre-hospital part of this session.
All right. Thank you, Dr. Ann, once again. So I was called and dispatched to actually transfer a patient from a lower facility to for advanced care. So I went with a driver and my co-paramedic with a Class C ambulance to transport the patient. So now we are going to actually hand over this patient to the hospital staff. So we shall use our ISBA handover tool where we shall start with the introduction. So Ariate Mbadaf, an EMT, and I'm from Ruaga Hospital Training School, handing over a patient who is 51 years and is a male patient. So getting to the hospital, the patient was dizzy and vomited blood of approximately 500 mils. He reports chronic epigastric pain. However, he says he's non-alcoholic and has not been using NSAIDs, but has been on omeprazole 40 milligrams for 4 days. So part of our assessment, the airway was clear and patent. Is breathing at 24 breaths per minute. Saturated spontaneous oxygen saturation is 93% on 2 liters of oxygen. The pulse is 120 beats per minute. The BP is 90 over 60 millimeters of mercury with pale, cold, and cold skin. The GCS is 15 of 15, and we are concerned of hypovolemic shock. So part of our recommendation, I would like to do a further workup and an emergency physician review. Then would like to do a gastroenterologist evaluation. We do blood grouping and cross-match for possible transfusion and continue IV fluids.
Thank you, Paul. Thank you, Duff. We'll have a poll that is running. Please, we shall end this poll in a minute once we've had at least 50% attempt. And according to the case that you've listened or heard, what are the key pre-hospital interventions for this patient? According to the case we've listened to from Duff, what are the key pre-hospital interventions for this patient? I have 15 people so far attempt, and once I reach 50%, we shall end the poll. What are the key pre-hospital interventions for this patient? Okay, it's exactly 1 minute and we have 54% attempt. We shall end this poll and move on to this patient presenting to the emergency department. Jasper, you're welcome.
Thank you so much, Victor. I'm Wafula Jasper Obale, a medical student from Goa University. And this presenter received just a minute. So received a 51-year-old
Jasper, we can't hear you.
I was getting calls this side. So received a 51-year-old man from DAS and did a primary survey. The air was patent and the patient was fully conscious. His respiratory rate was 21 breaths per minute and the SpO2 was 90% at room A. However, there was equal air entry. His pulse was weak and of low volume, but regular. He was tachycardic with a heart rate of 120 beats per minute, and his blood pressure was low. Systolic 98, diastolic 62 millimeters of mercury, and the capillary flow was less than 2 seconds. His GPS was 15 out of 15. The pupils were equal and reactive. However, he was hypoglycemic with 3.1 millimoles per liter. The extremities were cold. His body temperature was 36.4 degrees Celsius. He was very pale. He had a grade 2 bilateral PT edema. However, there was no bleeding. So, this is a patient who came with vomiting, blood wet sweats, constipation, epigastric, loss of appetite, headache, dizziness, and blood pressure. He had no any food and drug allergies. However, he had taken omeprazole 40 milligrams per day for 4 days. Past medical history was unremarkable. However, I was able to note severe anemia at a lower facility where he got 7 units of blood. Before referral, he had taken 36 hours before taking the meal. And the above signs and symptoms were the events that led to the presentation.
Okay, thank you, Jasper. We do have a second poll coming through. And from the primary and secondary survey that we've listened to, what are the emergencies in this patient? So we've done a primary survey. From the primary survey that has been done so far, what are the emergencies in this patient? Again, we'll bring this poll to a close once we have 50% attempt. You're doing well. Before a minute ends, 60% have attempted. Okay, so I'm going to bring this to a close in 1, 2. Okay, we end this poll, 70% attempt, and that's a good thing. Okay, so to the audience, is there any additional information that you would love to hear based on what we've so far heard from the pre-hospital team, down to the first presentation of the emergency department? Is there something that you think you would love to know that would help care for this patient, apart from secondary survey that we are yet to do? Feel free to type, which we may not allow unmuting, but just post your questions in the chat. Okay, someone would love to know what was the initial management of these patients. Okay, we're about to answer that shortly. Any information that you think is important that would help you to, okay, Jessica is asking about stool. Were there Melena stools? I think that's that will come through. Jasper will make that clear shortly. And then some case summary, I joined in late. Okay, so we have a 51-year-old male who was vomiting blood, and he had lost about 500 ml of blood. And we've done a primary survey, and we have potential emergencies that we are now yet to manage. I think that's a brief I can give about this patient. What was the indication of 40 milligrams of omeprazole? I think those were some of those things the expert will go in detail on us for the details of management. Okay, thank you very much. Dr. Emeron, based on the information that we so far had from the pre-hospital personnel down to the initial assessment in the ED, what are your thoughts? Do you think the team did well? Is there something that you would have done different for this particular patient? And how would you, if you are the physician possibly who are going to support evacuation of this patient, what would you tell the team to do differently? Yeah, thank you. Over to you, Dr. Emeron.
Thank you very much, and thank you to the team that handled this patient. Yeah, my thoughts on this patient is that we have someone who is getting into hemorrhagic, like well-established hemorrhagic shock, is really trying to compensate, and the approach that I see here is that these people went through the ABCD approach, and my feeling is that from the history that they have given to us, there is just an history of a chronic epigastric pain. There's maybe more history that we haven't, although we were given that there is no any other significant history. I'm thinking that something is going on in the abdomen. I mean, in the stomach. Potentially, maybe this is a bleeding peptic ulcer disease. That's what I'm thinking. But my approach towards this patient is not even about getting the diagnosis first. It's really to go through the ABCD approach, which I think the team has done well. In the first airway, from the assessment, the GCS is still 15/15. I think this patient is talking to them, and their airway is patent. But I'm worried about this patient because, like, they said 500 mils of blood. That's a lot of blood bleeding. So in my mind, I'm thinking I need to find a way to protect this airway. So I would be thinking about intubating this patient. May not be imminent now, but that's something I would be planning. And then when I look at their secondary, I mean the B, when you go to breathing, they did their assessment. I see the oxygen saturation is low. I mean, it's around 90%, and this is someone who has already lost blood. They are getting into shock. We know hypoxia sets in, so you need to give this person oxygen and bring it up. And that is something that I would really make sure that in this we put a mask and simple face mask, and make sure that this patient is getting oxygen. And then the other thing they did so well, in the C part, they established two large bore cannulas. And I think in this sort of setting, if you in the pre-hospital space, if you can get blood, or even in emergency, when you're putting these lines, get blood and be able to send them for grouping, cross-matching, and there are other things, coagulation profile, lactate, and other things that you may be able to do. But for once you've taken off the blood, you would try to get this patient fluid, but you have to be very careful with. We don't need to overload this patient with fluid, because we know fluid has a detrimental effect in diluting the clotting factor. Just to keep them the line open, and the best fluid to resuscitate this patient would be is blood. So in this, I will be looking at getting them more blood, and then monitoring them. And I think, to me, the really key things that I would do differently is the oxygen part of it, preparing to tube this patient, making sure that I'm optimizing these other vitals, and maybe I would be able to bring on board the other team member. Now, the things like the lab, and then if I'm in the emergency, I would be looking at bringing on other teams that I can collaborating with. And maybe the other thing could be trying an antiemetic in this kind of patients. So that's what I would do. But I'm thinking around that. There are other things. The more information I would actually want to know about this patient would be things like more drugs. They told us omeprazole. NSAID didn't use alcohol, but there are other sorts of drugs like clopidogrel, anticoagulants. This is a 51-year-old patient. It could be, although they say no any other issue, but I want to get to know other drugs that kind of interfere with the clotting mechanism. And I also want to know more history for behind there, like they transfuse this patient, how many units, and what any other investigations or whatever things they did the other side, so that we're able to kind of track. And he has pedoedema. There should have been bilateral. There should have been some other history I would want to take. And that's part of the history. But the bottom line, A, B, C, D, and then you go to sample, and then you can now get the other history. Stabilize the patient first, then you get into the other things. So thank you. That's what I would say about this patient at the moment. I may be able to give other things ahead of time.
Thank you, Dr. Imran. Jasper, I would like you to, before the poll, Jasper, just to put this into context, we are in an outbreak, so there is an overwhelming question on understanding you that could have come out possibly in your background or events leading. The team is wondering the history of travel for this patient and contact with people who are having vomiting. So I want you to clear that. All the other questions, I think we can handle them later on. Our expert will address most of them as we go down. But just kindly elaborate on us the history of travel for this patient. Thank you.
Thank you so much, Doctor. This is when I was really trying to speak with this patient, I tried to think about the Ebola bit of it and tracing the contact. However, this is a patient who came direct from home, a primary teacher, but he has been off his profession for some good years, but doing also farming at home. So when we really tried to trace his movements, we didn't really try to come out with whether he would really have come into contact with any person with Ebola. However, him vomiting blood really prompted us to think about Ebola. But when I tried to engage some medical personnel and the current criteria for diagnosis of Ebola, he wouldn't really meet it. Thank you.
Okay, thank you very much for putting that straight. Okay, so kindly can we have the poll for this next part? This poll is going to run for 30 seconds. I ask that we comply very fast. What are the emergency interventions for this patient? So the patient had 51-year-old male, vomited close to 500 mils of fluid or blood. And so we're wondering what could be the emergency interventions for this patient. What are the emergency interventions for this patient? Someone asked us a question that what was the initial management? And we're also asking you back the question. If tables were turned and you were managing this patient, what would you do immediately for the patient? We do have 40% attempts. Okay, 50% attempt, and I'll bring these to a close. Okay, I'll bring this to a close. Thank you. So over to you. Kindly walk us through over the next few minutes your intervention and what was running in your mind as management and what you did as investigations. Over to you.
Thank you so much, Doctor. After the primary survey, we had to do the ED intervention. Since his AR was patent, we just placed the patient in a recovery position, having in mind that his SpO2 was 90%. We placed the patient on oxygen 10 liters via a non-rebreather mask and then continuously monitored. Then I also withdrew blood for the CBC, urea and electrolytes, LFT, coagulation profile, and cross-match. Then we resuscitated with normal saline and then also placed the patient on 80 milligrams IV of omeprazole bolus and then continuously infused him with omeprazole 8 milligrams per hour. Having in mind that he was hypoglycemic with an RBS of 3.1 millimoles per liter, we placed him on 50 mils of dextrose 50% and then observed for any neurological deficits. Then we made sure that the patient was kept warm and then the temperatures were continuously monitored. So we went ahead to do the secondary survey. The head and neck, this person had severe conjunctival pallor. However, no signs of trauma. The chest was normal. The abdomen was soft, non-distended, and he had mild epigastric tenderness. However, no guarding, no rebound tenderness, no organomegalies, and his bowel sounds were 3 per minute. Doing the upper rectum, we found out a black tarry stool. However, no fresh blood or rectal masses. He had a grade 2 bilateral pitting edema. The extremities were cold, and the capillary refill was less than 2 seconds. His GCS was still 15 out of 15, and there were no any signs of neurological deficits that were observed. The skin was intact, no signs of trauma, and we didn't see any signs of spider nevi.
Dr. Emery, over to you.
Yeah.
At this point, is
Yeah,
there something else?
Yes, at this point, I'm really getting worried because of the conjunctival pallor. Now, I actually had thought about the current event of Ebola initially, and in this case, I am actually thinking that given in this patient, we say that he just got epigastric pain. He didn't even have any history, like maybe it had been there for some time, used those drugs. But what is really striking here is the conjunctival pallor. So with the conjunctival pallor, I'm now starting to think about, viral hemorrhagic fever. There should be something going about that. So I'll just play along with that mode. And even one of the things I didn't mention in the beginning is that these patients who have hematemesis, vomiting, IPC should be your number one mode when you're approaching them, even if they are not actually having a viral hemorrhagic fever, but there is a potential that these people can just vomit on you directly. So you've got to make sure that at least you put things to cover yourself, the apron, maybe the gumboots, if you have some googles, and you have to position yourself very well. And if they are conscious, you have a bucket around and be able to tell them in case they want to vomit. But some forms of Ebola, the fever may not be very prominent. You may just have a fatigue, you get other symptoms. And then, so in this case, that would be my, my thoughts. Many other diseases can present as epigastric pain, not just ulcers. It could be something to do with the chest, could be some disease, generalized kind of disease like in Ebola. So in this case, I would be worried. And I'm thinking that this is within Kampala, even if the patient is, doesn't have the travel history, and I'm assuming that this is Kampala. If it's Gulu, then maybe a different, but still someone can go there. So I would have that on top of my mind, but I will still go through my differentials. So now I'm thinking of possible viral hemorrhagic fever. PUD comes next, and then I'm having other things. There are so many causes I could think about. Maybe this could be a varicose hemorrhage. This could be some kind of gastritis, just or esophagitis. There are kind of a number of, but with a conjunctival hemorrhage, that changes my thoughts, and I want to know more history about this patient. You really have to, and then do more investigations to find out what is going on. So I would isolate this patient, and then now manage this patient as a possible hemorrhagic viral hemorrhagic fever. That's something that's coming into my mind by the fact that it has subconjunctival hemorrhage, because it's one of the presentation of viral hemorrhagic fevers. So that's my thought. But the most important is IPC, stabilize your patient and work out the investigations. So if you're suspecting that in this mode, then you'd have to find a way to take off the sample for for Ebola as well at this time, and involve the team that is really concerned with that. Just ceases to be your own case. You have to involve other people in this kind of case.
Okay, thank you so much, Dr. Imran. Over to you, Jasper. Kindly walk us through how you concluded on the care of this patient and then the investigations. Thank you.
So, based on the history, we came out with a problem list. Number one on the list was a hypovolemic shock in view of the tachycardia, the hypotension, the cold extremities. Then 2 was a severe anemia, the severe conjunctival pallor that was observed. Then hypoxemia, the SpO2 was 90%. Hypoglycemia was a 3.1. The grade 2 bilateral pedal edema, and then the epigastric pain.
Our fourth and last poll, based on what we've so far listened to and managed, what are the key investigations for this patient bedside? If you are the one managing this patient and you've listened to the story, the examination, what would be your key investigations, emergent bedside investigations? Okay, we have 43% attempts. Let's all attempt. We shall have a rerun through these polls, so don't worry. We shall see what answer made most sense or what was the best answer. So we do have a 54% attempt, and I would love to bring this poll to a close. Okay, so Jasper, over to you.
So following the history and the presentation of the patient, we're prompted to do these investigations. The CBC to assess the severity of the anemia, the platelet count, and any evidence of infection. Then the blood group and cross-match, obviously, to provide a compatible blood for the urgent transfusion. Then the HIV, hepatitis B and C. Hepatitis B and C would be one of the baselines for the we usually do before any transfusion, and maybe to assess any liver disease. Then the urea and electrolytes to assess the renal function, dehydration because he was vomiting, and then any electrolyte abnormalities. LFTs to assess the liver disease, abdominal ultrasound. This would help us to evaluate any hepatobiliary pathology. We also were prompted also to do the coagulation profile, and this one would help us to rule out any coagulopathies. And then the second last we thought about was endoscopy, and then lastly was H. pylori. Endoscopy would definitely help us to come out with a definitive diagnosis and management of this patient. So following the investigations, these are the results that we really got, and I was able to summarize them on the next slide. The CBC, we found out the white blood cells were high. He had lymphocytosis, neutrophilia. The HB was low of about 5.8. He had microcytic hypochromic anemia following the CBC, and then he also had thrombocytosis. The LFTs, we found out he had a mild direct bilirubinemia, then the AST was also elevated. The abdominal ultrasound was normal. Malaria, HIV, hepatitis B and C, they were all negative. However, pending endoscopy and the H. pylori. So our differentials are following the history and the investigations. We thought of erosive gastritis, a bleeding peptic ulcer disease mostly. We also thought of esophageal varices, ectopic varices, bleeding gastric carcinoma, all in view of the hematemesis, and then the complications of the bleeding, the hypotension, the tachycardia. Then the vesicular lesions, also thought of the Deuler-Foy's lesion, angiodysplasias, and then lastly, the Mallory Weiss tear. However, he never reported any phosphoretching during So we came out with a working diagnosis of upper GI bleeding. In view of the hematemesis, the hypotension, the tachycardia, and the cold extremities. Yeah.
Okay, thank you so much, Jasper. I think we are now getting there. We are starting to understand your patient and to appreciate what the team at ground had in mind and also had at hand. I believe you did a good job. Over to you, Dr. Emron. At this point, what we've so far had and what we've so far done for the patient, what are your thoughts?
Yeah. Thank you very much. Yeah, so this is really an interesting case, and the thought process I have is that this patient in some way is getting some sort of potential organ organ damage. We didn't get some other tests, the coagulation, and then I think LFTs and the other. But clearly, there is some aspect of the liver going through some issues, although it is not really very marked. And there is some sort of, a lot of bleeding, the GIT bleeding. There is an upper GI bleed. Based on the melena and then also vomiting, and it's kind of like a lot of bleed. And this patient has spent some time in shock based on the HB, but also the timing, they transfuse from there, and sort of like this bleeding is not getting better despite the intervention. So I think it's something big, and it's coming from possibly from the stomach, unlike the esophagus, because this to me, we categorize upper GI bleed as variceal and non-variceal. So it's likely to be a non-variceal bleed, which could be coming from the stomach. But I still keeping my differential of the infectious disease going on, because it can also affect different organs. It can affect the liver, and it could still affect other things. The only thing I notice here, there is some bit of conjunctival hemorrhage. There is some bit of, we haven't heard whether there was bleeding from any other part, but also the platelets really looked okay in this case. Some cases of viral hemorrhagic fevers, the platelets are a bit down. So
Dr.
I'm still
Emran,
left there. Yes?
Dr. Emran, he had
Yes?
conjunctival pallor, not hemorrhage.
Oh. That I didn't notice that. So this is I would be going with potential PUD, possibly peptic ulcer disease bleeding, which could and that could be just ulcer, or he's been having some sort of malignancy. It is really not that sort of potential risk factors for malignancy, and the symptom didn't come out clearly. But I would bet on peptic ulcer disease. I thought it was something to do with the conjunctivitis, or subconjunctival hemorrhage or something. So I would go with PUD and the gastritis, some kind of maybe malignancy or some kind of malformation. In this case, that's what I would think more, as opposed to variceal bleeding. And in terms of management is it is stabilizing this patient, and this case now investigating. The topmost here would be endoscopy. I would want to really do endoscopy within if possible 12 hours or 24 hours, so that we can be able to get the diagnosis early and even treat, because endoscopy doesn't only do diagnosis, it can also do treatment. I would want to get endoscopy as quickly as possible.
Okay, thank you so much, Dr. Emran. Maybe I think my question or something I want you to address will come through when we are doing the next phase. For now, let's just conclude, and then we'll ask you to address some things. Over to you, Jasper.
Thank you, doctor. So we admitted this patient to the medical ward, continued the IV omeprazole, and then following the CBC results, we placed him on ceftriaxone 1 gram OD, and then the metronidazole 500 milligrams 8 hourly. Supportive management, we kept him on IV dextrose following the hypoglycemia, then oxygen following the low SpO2, and then 1 unit of packed red blood cells was transfused. He was kept nil per os, preparing him for endoscopy, and then we did serial vital sign monitoring and HB. Our plan for this patient was to monitor continuously, and then take him for upper GI endoscopy within 24 hours, and then also test for for H. pylori, and then continue the PPIs.
Okay, thank you so much, Jasper, for the work well done and for accepting to share this case with us. And just before you give us your take-home message, we would love to ask Dr. Emron to share with us the pearls and pitfalls, specifically from the chart. I think I'll just highlight a few things so that we don't get them missed. So there was a big contention on one, the use of omeprazole in this particular patient. Why was it chosen? And then two, something that may not be asked, but I think it would be good we highlight on it because these are our incoming interns in a year or two. Blood versus fluid in a patient who has lost blood. Because there was someone who mentioned permissive hypotension somewhere there. Yes, but maybe you just also address for us that, and then maybe the last one would be use of the anticoagulants, because it was also a question in the chat, and then maybe fibrinolytics, maybe using tranexamic acid. Yes, for this particular patient, maybe you could use over the next 5 minutes, so that we can give pearls and pitfalls. Thank you very much.
Okay. Yeah, thank you very much. The pulse for this particular case is that you have to think that the bleeding will kill your patient first, and the diagnosis will be second. So you wouldn't want to be distracted so much on history before stabilization. Walk through your ABCD and stabilize your patient, and treat this vomiting patient. It's really a life-threatening event, and stabilize your patient. Then as your is getting stable, you can now pick out this history. But also, interestingly, in this kind of, I'm happy that it came out in this era of Ebola. Have that in mind, and make sure that you have your IPC. The second thing is, when we are looking at these patients, is your airway protection is also often a real killer. We know they are bleeding, but no, when they bleed, they get into shock, they lose the consciousness and airway. So in this case, prioritize your airway as early as possible. Don't wait until really someone has lost full consciousness. Then you start to find ways of protecting the airway. And the resuscitation, 2 large bore cannula, take your samples and then start these patients on fluid. Now, in terms of resuscitation for these patients, especially if they have lost a lot of blood, let's say about 3 liters, and then they are in shock. This actually can call for massive transfusion protocol. And the guidelines today say that it's better to transfuse, in ratios of like 1:1:1, which is like you have to take maybe packed red blood cells, fresh frozen plasma, and platelets. Because remember, when these patients are bleeding, they are forming clots, they are utilizing. When you replace only the blood, you're not replacing the other factors, and these patients can just go on bleeding and bleeding. So that's a better strategy. You replace these whole 3 things rather than just giving them packed cells. Now, the best fluid to replace blood loss is blood. However, you can give them the crystalloids just as initial, as you're waiting for the blood. And in my opinion, depending on the age group, you shouldn't go beyond 1 liter if it's an adult. just keep the line as you're getting the blood. There's something we call permissive hypotension. You're just keeping the BPs to a level where, the vital organs are perfused, the brain, the kidneys. And how you can know that is if your patient is mentally okay, like they are talking to you, or if they are altered, and then you bring their BP to a point where they are talking to you, they're able to understand. That's the point that you should be targeting. So try as much as possible not to give a lot of fluid. Get blood as fast as possible, and when you're in a center that's able to give those different products, prioritize getting them or all the three products. Now, the other thing is we talked about fibrinolytic. A lot of there's a big study that was done in 2020 which showed that fibrinolytics have no benefit for patients who have upper GI bleeding, unless if the bleeding is like from trauma. Trauma patients, if you damage your upper airway and then you kind of swallow the blood and then you end up vomiting. In a trauma, we know tranexamic acid works. But if it's variceal bleeding or peptic ulcer disease, it has been demonstrated that there is no benefit, either reducing rebleeding or the amount of clotting, consumption of blood, or the length of stay, or improvement of mortality. So at the moment, that is not there. I know that some people still practice and they still believe in that, but the current studies show that that is not useful. And then the use of anticoagulants. So anticoagulants would actually make this worse. Just think of it. You're having somewhere bleeding and then you give someone anticoagulant. In fact, if these patients had anticoagulants, you'd stop them. And if they were on, let's say, warfarin, you'd even give them like vitamin K and try to reverse those anticoagulants. So some of the other things you should know, that when these patients lose blood, they will compensate. So sometimes you get the vitals assumingly like they are normal and sort of reassuring, but actually your patient is falling down. And don't stick to the HBS, especially initially. When you do HB, it may give you a wrong impression and then you fail to. And we should try to get these patients to have an endoscopy as early as possible, especially if you think that it's either it is a variceal or PUD, because it's both diagnostic and it's also therapeutic. And we are discussing this is like a PUD, but in general, if you think it's variceal, like varices, think about antibiotics for spontaneous bacterial peritonitis, and then think of adjuvants like erythromycin. In this case, erythromycin helps you to take away the blood which is in the stomach. Is a prokinetic, so it improves on the endoscopy. You do it once instead of repeating. Sometimes you go there and find a lot of clots. Antiemetics, they may make your patient comfortable. Now, PPIs are very good in non-variceal, meaning not varices, but in cases of PUD. Why? Because first of all, we know the formation of ulcer. When you get ulcers, it is the acid that plays a role. So it will reduce on the acid. Also, when you reduce on the acidic environment in the abdomen, in the stomach, it can stabilize the clot, and research has shown that it will reduce rebleeding, the episodes of bleeding due to PUD. So if you use this, it will reduce on that. It will also improve on hospital stay. So they have a benefit in patients who have non-variceal bleeding. And I would really say focusing on history before stabilization, that is it. Should do not really prioritize that really. And you should try not to over resuscitate your patient with it. Don't try to over resuscitate with the fluids. So, and I think when you're thinking through your ABCD, the biggest problem is C, which is the circulation. You're losing blood, but that C will give you problems in A and actually potentially B, and the other things will come in. And when you are managing shock, of course, don't forget the other things like covering your patient, warm fluids, IPC, taking yourself, keeping yourself safe on that. And don't forget to think about infectious diseases. Don't delay airway protection, don't delay resuscitation, don't delay targeted therapies that can actually help your patient. There are other therapies that are good for non-varicose, like octreotide. They kind of cause vasoconstriction and stop the bleeding. But in this case, we are talking about PUD. So maybe we'll address that in another session. But think of stabilizing your patient, take your history. If they are not getting stable very fast, involve other teams, get your endoscopy as quick as possible, and that may save our patients. Thank you very much. If there's something else I have missed, maybe Annie will remind me and I can answer the questions.
Thank you, Dr. Imran. The rest of the questions will be answered in the podcast. Otherwise, thank you so much. I think you've addressed most of the concerns. People are not satisfied about the TXA, but please, let's believe science. Studies are there and they've been done. Okay, so Jasper, in a minute, give us your take-home points, and then we shall bring this to a close.
Thank you so much, Doctor. Following our case, it was an upper GI emergency, and for that particular case, we are supposed to do an early recognition and risk stratification. Usually, it is the risk stratification is usually done using the GBS. Greater than 2 patients are treated as inpatients, and 0 to 1 are treated as outpatients. Thereafter, you do a prompt ABC resuscitation, and then an upper GI endoscopy should be done within 24 hours, as this will help us on diagnosis and the definitive management of the patient. Among other causes, the PUD stands as the commonest cause, and for that case, we test and eradicate H. pylori as one of the causes for it. Ceftriaxone has the highest morbidity benefit in patients who have liver cirrhosis and variceal bleeding, just like the expert has spoken about SBP, the spontaneous bacterial peritonitis. And then lastly, you patient educate about the risk factors that might maybe exacerbate or prompt them to come back to the hospital for the same particular case. Thank you so much.
Okay, thank you so much, Jasper. We're going to share the results from our poll, just for everyone to take home something from these polls. IT, kindly share the results. Okay, thank you. So the first question was, what are the key pre-hospital interventions for this patient? No, that was, yes, pre-hospital, yes. So for this patient, majority of us, 93 of us, actually did a good choice. We chose that we maintain the airway, put large bore cannula, and do continuous monitoring, which was a right choice for this patient. The second question was, from the primary survey, what are the emergencies in this patient? And again, majority of us were able to tease out what these were, and we identified rightly the hypovolemic shock, the hypoxia, and the severe anemia. And then the third question, what are the emergency interventions for this patient? Again, majority of us were able to identify the immediate intervention, and that's the crystalloids, massive transfusion, and oxygen supplementation. And lastly, the key bedside investigations. Again, most of us equally picked this up so fast. Full blood count, grouping and cross match, and then lastly an endoscopy. Thank you very much. This was well done. I think the team is doing so well, and it's 1 minute on top of the hour, and I would love to bring this to a close. Thank you everyone for joining in to our sessions. Once again, we run this once a month, and we do invite presenters from the different universities. I think most of you have been added to our CPC forum. In case you see a patient that is really interesting, feel free to reach out and take on this tape and share with us. If you have a mentor or you've worked with someone, maybe a physician or a surgeon, whoever you've worked with and is happy to come along and share information, we'll be glad to have them on our sessions, on our platforms. Once again, thank you from the CPC team to the rest of you. Have a wonderful evening, and thank you for joining in. Bye.